Hmm? A very good evening to one and all present here, dear students. So, firstly, to begin with this topic, I would like to thank Dr. Sunil sir for providing all of us such a huge platform and helping you students to clear all your concepts. Okay, so my name is Dr. Vedi Shah, and I'm the faculty of obstetrics and gynecology, and I'm going to take a live lecture of you all. The topic for today is the third stage of labor as well as the postpartum hemorrhage. Now, before we begin this session, I would like all of you to just help us all by subscribing to the YouTube channel, and you can also avail the promo. You can also avail the session for 3 months with using the promo code which is given in the link below. Okay, so let's begin with today's topic, which is the third stage of the labor as well as the postpartum hemorrhage. Okay, so what do you all mean by the third stage of labor? So this is also called as the stage of the expulsion of the afterbirths, which is consisting of the expulsion of the placenta, the umbilical cord, as well as the membrane. Okay, now if I talk about this, it consists of various stages. Once again. Yeah, so it consists of various stages. Okay, so this stage includes two particular stages. The first is the stage of the separation, which is followed by the stage of the expulsion of the placenta. Okay, now why is this stage so important? So if the third stage, so following the delivery of a baby, what happens is if the mother is not taken care and the third stage is not carefully managed, what happens is the catastrophic events can take place, and the mother can well, it can lead to blood loss in the mother, and it can result into the death of the mother as well. So in order to improve the reduce the maternal morbidity as well as tackle the maternal mortality, what we need to understand is the postpartum hemorrhage, which is a complication of the third stage of labor, and what we all as the doctors should try to reduce this complication. Okay, so the first step would be the stage of the placental separation. So following delivery, the uterus is going to undergo the sudden reduction in the size as well as it starts shrinking. What happens to the uterine muscles is it is going to undergo the two phases. First is the contraction. The uterine muscles undergo contraction, and the other processes it is going to go the retraction. Okay. So because of the continuous contraction and the retraction of the uterine muscle which is taking place, what happens is the uterus is going to contract, and it lies below the level, or it lies at the level of the umbilicus, and it appears to be as large as the size of the fetal head, which is around 10 centimeter. Okay, so it lies just at the level of the umbilicus. Now, what happens once the delivery of the fetus takes place inside the body, the further oxytocin release keeps on going on, and the uterus still starts contracting further. And as a result of which, there's a discrepancy between the surface area of the attachment of the site of placenta as well as the placental size that is created. Okay, so there is discrepancy which takes place. So let's consider this as the uterus, and this is the size of the placenta, and this is a site where the placenta is going to get attached. So once the delivery of the fetus takes place, because of the contraction of the uterine muscles as well as the retraction which is taking place, what happens is this site is going to get reduced in its surface area, But the placenta is going to be an inelastic structure, and as a result of which there is a shearing force which is occurring between the site of the placental attachment and the size of the placenta. So this leads to the initiation of the separation of the placenta. Okay, so again, the great disproportion is going to be produced between the placental attachment site as well as the size of the placenta, which is going to bring about the separation of the placenta. And there is a plane of cleavage which is created. Now, this plane of cleavage is very important, which is at the site of the decidua. Okay, so decidua spongiosa is the site where the separation of placenta begins. Now, if you talk about various signs of the placental separation, so what you see is there are certain per abdominal signs as well as certain per vaginal signs. So if we talk about the per abdominal sign, so what happens is once the patient has delivered the baby, if you wait for a certain time, what happens is the patient is going to be in the labor room and the baby has been delivered. Now, the immediate step is you see the signs of the placental separation, whether the placenta has been separated or not. So for that, what you are going to do is you are going to check it per abdominally, and what you find is the slight amount of the change in the consistency of the uterus. That is, uterus is going to become per abdominally. It is going to become globular, extremely firm, because it's a muscular structure. It is going to contract. It becomes firm and easily ballotable. Means you can hold the uterus, and you can move it side by side. So this is going to be the earliest sign. Okay, so there is a change in the consistency of the uterus, which becomes firmly contracted, as well as it can be moved side by side, which is called as the easily ballotable. Okay, next what you see is the further separation of the placenta which is taking place. So what happens is, let's consider this as the uterus. Okay, and here the placenta starts lying. The placenta is separated and it is going to lie in the lower segment. So what happens is, because the placenta occupies the lower uterine segment, there is a slight amount of the suprapubic bulge. Here, there is a pubic bone anteriorly which is present. So what you see is, because of the presence of the placenta in the lower uterine segment, what you are going to notice is certain kind of the suprapubic bulge. So this suprapubic bulge is noted. Okay, apart from that, since the placenta is going to lie in the lower uterine segment, the part of the fundus which is going to rest above the separated placenta, and this causes this slight increase in the fundal height. So this increase in the fundal height is going to be called as the Schroeder's sign. Okay, next what you see is the Kushner sign. So what happens, which means what? Now, since these two structures have already been separated, that is now because of the separation, what you see is the placenta has been already separated from the uterus. So once you try to per abdominally, if you're trying to push the uterus above, what happens is the cord is not going, the cord length remains there, and this is going to be called as the Kushner sign. So that was about the per abdominal signs, what we see in a case of the separated placenta. Similarly, there are certain other signs what you also observe per vaginally, and which is as follows. So because of the separation of placenta, what happens is, so let's consider this as the uterus. And this is the separated placenta which is lying. Along with that, this is going to be the cord which is attached to the placenta. And what you're seeing is per vaginally. So because of the separated placenta, there is certain amount of the blood vessel sinuses which are getting torn, because of which the blood is coming. It is seeping between the placenta as well as the uterus, and it is seen per vaginally, and that is going to be called as, you can see the sudden gush of blood which is coming to the toned uterine sinuses, which will lead to the sudden gush of blood. So that is about number one, per vaginal sign. And the second what you see is going to be, because this placenta has been already separated, and there is this cord which is attached to the placenta. So both of these structures are going to move down, and this is going to produce the permanent lengthening of the cord. So despite the per abdominally, what you were seeing, what you were interpreting the permanent lengthening cord was that you are pushing the uterine fundus upwards, and the cord is not going to recede inferiorly. So that is going to be called as the Kushner sign, whereas per vaginally, the same thing is seen as the permanent lengthening of the cord. So that was all about the signs of the placental separation. Next, how is it going to separate? So there are basically two ways how the placenta can get separated from the uterine surface. The note that it is going to separate at the level of the decidua. So now there are two methods. So first is the Schultz sign and the Schultz method, and the other one is going to be the Duncan's method of the separation. Okay, so if you talk about the Schultz sign, what happens in case of Schultz method? This is most common method of the separation of the placenta, where the separation takes place or starts posteriorly with there is retroplacental blood vessels, that is retroplacental collection of the blood takes place, which is beginning at the center. So because of that, what happens is that since the separation is going to begin at the center of the placenta in the posterior surface, there is the collection of blood which starts, and it is going to push the whole of the placenta downwards, as a result of which what happens is this is going to be the fetal surface where the cord is attached, which is going to be shiny. So shiny fetal surface where the cord is attached, it firstly appears at the vulva. Okay, so that is going to be the most common method. Now, since here what happens is the blood starts collecting posteriorly just behind the placenta, the amount of the blood loss is going, the placenta gets separated from the underlying from the underlying decidua because of the pressure which is created by the expanding retroplacental clot. So as a result of which the amount of the blood which is collecting behind is going to be limited. Whereas in case of the other method, which is going to be the Duncan's method of separation, what happens is it is going to be the placenta starts separating from the margins. Okay, so it starts separating from the margins. As you can see in this picture, it starts separating from the margins. And as a result of which, the first sign which you see in this kind of case is going to be the bleeding which is taking place. So the placental surface which you are seeing is going to be the mother's side of the placenta, which is going to be little bit dirty, spongiosum, or the cotyledons which you are going to see. So dirty maternal surface, which is for the Duncan Matthew. Okay, so D for Duncan Matthew and D for the dirty maternal surface. Now, since there is no kind of the pressure tamponade which is created and the blood is leaking from the margins or from the periphery, what you're going to observe is that the amount of the blood loss which is taking place in this method is going to be relatively more compared to that of the Schultz method. Okay, and this is relatively seen in the lesser number of cases, which is only in 20% of the cases. Next, we move on to how you're going to manage such a third stage of labor. So first we talked about was the how the placenta is getting separated. Okay. Next is the expulsion of placenta, which is taking place, which is because of the maternal efforts. Okay. And along with that, it is also assisted by the attending obstetrician or the midwifery. Now, how you're going to manage a patient, any laboring patient which is coming to the labor room once the baby is delivered, the next step is the management of the third stage of the labor, that is the removal of the placenta, which is and checking for the intactness. So what you're going to do is this third stage includes the separation, the descent, and the expulsion of the placenta along with the membranes. And what you see is the signs of the placental separation. Okay, so what next is there are two main methods how you're going to manage such a patient. So initially there was what used to happen was there was expectant management which was carried out. Now what we more prefer is the active management of the third stage of labor, which is done. Okay, so in case of the expectant management, what does expectant management means you allow it to go on its own. Okay, so what is the literal meaning of the expectant management means you allow the process to occur on its own, that is leave the things to nature. So what you're going to do in such kind of management is that just await for the spontaneous placental separation, and once this placenta is separated on its own, you allow it for the descent of this placenta inside the vagina. Ask the mother to gently bear down, and once the placenta is visible at the introitus, okay, what you're going to do is the obstetrician holds the placenta, removes it by the twisting method, and checks for the intactness. So that is how the expected management is going to be carried out, okay, which is not done these days. What we do these days is going to be the active management of the third stage of the labor. So in case of the, why is this active management of the third stage of labor has been developed? Because this, we know that the third stage of the labor is going to be most crucial, because if it is not attended properly, if it is, there is some kind of, let's say we leave the things to nature, what happens, there are very high chances that the mishaps can develop in this phase, and it can lead to the development of the maternal mortality as well as morbidity in terms of the grave consequences such as the postpartum hemorrhage. So in order to prevent the postpartum hemorrhage, what we do is we inculcate this kind of the active management of third stage of labor in each case. That is, the obstetrician is actively intervening. Now there are a few steps. What you're going to do is this. So what is the principle behind this? That is, we all know that once the delivery of the baby is taking place, there is large amount of the oxytocin which has been released in the body, which is going to cause the uterine contraction. So what we are doing here is we are simulating that of the nature. So what we do is, externally we are going to give the parental oxytocin. Okay, so we are going to give parental oxytocin, which goes and acts, produces a strong uterine contraction following the delivery of the fetus. Thus, this is going to prevent the development of the further, it thus prevents the development of the postpartum hemorrhage. So our basic principle or our aim is to prevent the development of postpartum hemorrhage. And what we do is that we are going to give the parental oxytocin, thus helping in the strong uterine contraction. So there are various components of this. So what happens, what we use here is, as I mentioned, parental oxytocin is used, number one. Number two is we go for active delivery of the placenta. That is, the placenta is delivered by the method of the controlled cord traction. I'll be describing this controlled cord traction in detail in the next slide. Next is you go for the delayed cord clamping. So what happens is, once the delivery of the placenta takes place, once the baby is delivered, what happens, let's consider this as the baby, it is the umbilicus, and here is going to be the placenta. So even if the baby is delivered, we allow approximately 80 ml of the blood from the placenta to be drained into the fetus. So we check for the pulsations in the cord. Once this cord pulsations are absent, then and then only we proceed with the cutting of the cord. Okay, initially what happened, we used to go for the immediate cord clamping once the baby was delivered, but now what we are observing is we are applying is the delayed cord clamping, where we allow the spontaneous loss of the cord pulsation, so that what happens, we deliver extra 80 ml of the fetal blood to the fetus from the placenta, as a result of which there are lesser chances of the development of the anemia in the baby. Okay, lastly, we go for checking the tone of the uterus intermittently. So initially, previously, what used to be done was the uterine massaging, but note that uterine massaging is not a component of active management of third stage of labor. Just we need to know that the uterus is properly contracted. By then, this is done by assessing the tone of the uterus. Okay, so if we talk about the oxytocin, what happens is, in case of oxytocin, we are going to give the oxytocin parenterally, and this will help in prevention of the postpartum hemorrhage. So here we are going to give the 10 units of oxytocin by IM. Okay, so 10 units is given intramuscularly following the delivery of the fetus. Now, this particular thing is not carried out in the twin pregnancy. Okay, once the first twin is delivered, what you're not going to do is, the first twin is delivered, you're not going to give oxytocin, because it may cause the compromise to the second twin which is inside the uterus. So this active management would be giving oxytocin following the delivery of the fetus. First fetus is contraindicated in the case of the twin pregnancy. Otherwise, what we go for, routinely giving the 10 units of oxytocin intramuscularly following the delivery of the fetus. Now, sometimes what happens is, there are high risk conditions where you can give, instead of giving it intramuscularly, you can also give the oxytocin drip, which is given as the concentrated oxytocin drip, where you can give the 40 units of the oxytocin in the 500 cc of NS. Okay, that is going to be given as a treatment, or you can also give in the dose of 20 units of the oxytocin in 500 cc NS. One more thing you need to give, or you need to be very careful while giving, is that never ever give the oxytocin direct intravenously. Okay, if you're giving it as the IV bolus, okay, you're directly giving it in the intravenous line. What happens is there is sudden risk of the development of the hypotension to the fetus, to the mother, as well as it can lead to the cardiac arrest. Okay, so that is because there is transient fall in the blood pressure which is going to take place. Along with that, there is the abrupt increase in the cardiac output, as well as the development of the chest pain and the myocardial infarction. So you have to avoid. So if you want to give it intravenously, how are you going to give it? You have to dilute it and give it as the infusion rather than just giving it as the IV bolus. Earlier, apart from oxytocin, the ergomytron as well as methyl ergomytron was also used for the routine prophylaxis, but that is actually less preferred because it has a very high risk of development of the sudden hypertension in those patients who might be having cardiac disease or might be having preeclampsia. So if you do not know that the mother is having the history of cardiac disease or not, then for the safety of the mother, you have to avoid the methogen as well as the methyl ergomytrin. Rather, it is always safe to use the oxytocin. Okay. What happens in the certain cases like the grand multipara, where the uterus is going to be bit of the flabby and there is poor contractility as well as poor retractability? What happens? You have to give a larger dose of the oxytocin to these mothers, as well as in those patients whom you have induced the labor. You need to give a bit concentrated, or you have to give bit the oxytocin for a bit longer duration. What you're going to give is the infusion is done, which is at the 20 cc in 500 cc of NS. So that was the dose as well as the particular things you need to note about while giving oxytocin to the mother. The next component of the active management of the third stage of the labor is going to be the controlled cord traction. Okay, that was controlled cord traction, and it is going to also be called as the modified Brand and Drew technique, where what you're going to do is, with one hand, you are going to hold the cord, which is done with your dominant hand, that is the right hand. Simultaneously, you are going to push the uterus upwards by the non-dominant hand, or most probably the left hand. So what you're going to do is the fundus is pushed upwards and backwards when the uterus is firm. So you need to know that with the hand which is kept on the uterus, you need to see whether the uterus has already been contracted or not. That is, has it become firm or not, number one. And this is also a sign whether placenta is separated. So once that is done, you're going to push the uterus upwards and backwards. Simultaneously, you have to hold the cord with the second hand, which is the dominant hand or the right hand, and give the gentle traction, okay, controlled traction with the dominant hand. What you're going to do is in the downwards and backwards direction. So a steady traction is given. Now, you need to note that never pull. Okay, if you're going to pull the placenta, what you're going to predispose is the inversion of the uterus, which can precipitate sudden massive postpartum hemorrhage. Okay, so that was about the controlled cord traction or the modified Brand and Drew technique. Now we come to the catastrophe, which is going to be the postpartum hemorrhage. Okay, so what I was continuously talking in the previous slides was the postpartum hemorrhage. So if you want to prevent, or if you want to make the third stage uneventful, what you need to be very careful is that and manage the third stage of labor with the help of active management of third stage of labor. If this is not managed judiciously, what happens? It can lead to the development of the postpartum hemorrhage. So what is that? So it is the blood loss which is taking place in more than the quantity, which can lead to the hemodynamic instability in the mother. So how will you define that? What is the amount of the blood loss, or what are the signs, or to what extent I would call that this particular blood loss is occurring? It is called as the postpartum hemorrhage. So there are certain things which are called as normal, which is taking place after delivery. So what is this? That following the normal vaginal delivery, what happens is you can expect around 500 cc of the blood loss, which is going to be called as normal if a mother is undergoing the cesarean section. Okay, cesarean section, what you can expect is 1 liter of blood loss would be considered as normal. And if it is the obstetric hysterectomy, okay, it is up to 1.5 liters. So these are the normal criteria. Now, any blood which is exceeding blood loss, which is exceeding this particular limits, can be considered as the postpartum hemorrhage. So apart from that, there are certain quantitative definitions as well as certain clinical definitions which have been developed, which help us, any obstetrician, to help in the further management. So first we talk about is the quantitative definition. So if the blood loss is going to be more than 500 ml following the birth of the baby up to the end of puerperium. So there's this duration which has been defined, that is immediately following the delivery up to 6 weeks, that is the end of the puerperium. That is going to be the time limit. So any amount of the blood loss which is exceeding more than 500 ml, that is the first. Now, in this time duration, what we are further dividing is that if the blood loss is taking place in the first 24 hours, that is going to be called as the primary postpartum hemorrhage. Whereas if it is taking place after the 24 hours, it is going to be called as the secondary postpartum hemorrhage. Now, the ACOG is telling that any blood loss, irrespective of the mode of delivery, whether it is cesarean section, whether it is obstetric hysterectomy, whether it is going to be the normal vaginal delivery, if the blood loss is going to be more than 1 liter, then irrespective of the mode of delivery, it is considered to be the postpartum hemorrhage. Now, I told that if an obstetrician is sitting in the labor room, okay, and there is no means that what we see is that it is only the amount of blood loss could be only visually assessed. You cannot estimate the amount of blood loss and you cannot quantify. So instead of just quantifying the blood loss, what is happening is that we go for the clinically defining how the postpartum hemorrhage is developed or not. So what there are certain signs and symptoms which help us in defining. So irrespective of any amount of the blood loss post-delivery, what happens is the amount of blood loss, if it is sufficient to make the patient hemodynamically unstable, then that is going to be called as clinically defined as the development of the postpartum hemorrhage. And by that, what I mean is the development of either fall in SpO2 or the tachycardia or hypotension development or increase in the respiratory rate. So these are the hemodynamic instability which is produced because of the bleeding, and that can be considered as a clinically postpartum hemorrhage. Other definition is the drop in the hematocrit. Hematocrit is what? It's the packed cell volume. Okay, if it is less than 10% or the 10% drop in the hematocrit which is taking place, or it is requiring the immediate blood transfusion, then that is definitely short that it is a postpartum hemorrhage. Now, before understanding what is taking place, I'll briefly describe what is the physiology which is behind all these. So what happens is once the delivery of the baby takes place, we all know that the uterine muscles are arranged in the normal crisscross pattern in the intermediate layer, and in between them, there is this blood vessels which are passing through it. Okay, so the myometrial fibers are arranged in the crisscross pattern, and the blood vessels are passing in between that. Now, in any mother who is going to be pregnant, what happens is there is the plasma volume which is going to be increasing by around 50%. Okay, so plasma volume increases by 50%, number one. Simultaneously, there is second thing which is called as the hemo dilution. Okay, hemo dilution, that is the relative hemo dilution which is taking place. Now, all these physiology is going to help mother prepare for the future blood loss which is going to take place following the delivery of the fetus. Okay, so this helps in tolerating the blood loss which is going to take place, while the nature itself is going to increase the plasma volume by 50%, as well as the red blood cell volume which is going to increase by 40%, making a development of the relative physiological hemodilution. Now, if such a mother is going to have anemia, that is before pregnancy, what happens is her level of oxygen carrying capacity is very low. What happens? she can't afford to lose even slight amount of the blood. So whenever this physiological amount of the blood which is going to be lost, the effect to the mother produced is going to be very large. Okay, so therefore the patients with anemia are going to require the correction of the blood before the delivery is going to take place. So that is number one. So those patients who are having anemia are very high risk patients for the development of the postpartum hemorrhage. The other thing you need to note in such patients with anemia is that their oxygen carrying capacity is already low. Okay, now we all know that the uterine muscle fibers are ultimately they are muscles and they function on the basis of ATPase enzyme. So even since the oxygen coming to these uterine muscles is going to be low, the ATPase cannot function properly, and as a result of which they are predisposed to development of the uterine atony. Okay, so that was about the patients with anemia. Now we talk about those patients with preeclampsia, where there is hemo concentration as well as there is loss of the fluid into the third space. That is, the patient is with preeclampsia, which means there is high blood pressure as well as albuminuria is going to develop the edema or the loss of the fluid into the third space. So there is a condition of a relative fluid loss into the third space, as well as there is hemo concentration which is taking place. So the effective blood inside these patients is also going to be low. So a slight amount of the blood loss which is taking place in this patient can also lead to precipitate a hemodynamic postpartum hemorrhage. So these two are the conditions where they are very highly predisposed to the development of the postpartum hemorrhage. Now, this is already I mentioned that the average blood loss which is taking place in the vaginal delivery is going to be 500 cc, as well as in cesarean section it is going to be 1 liter, as well as in the case of the cesarean hysterectomy is going to be really 1.5 liters. Now, we are categorizing that, is it, if the postpartum hemorrhage has taken place in a mother, is it going to be a mild variety, moderate variety, or it is going to be severe? So the classification is if the amount is going to be 500 to 1 liter, it is going to be called as the minor amount of the postpartum hemorrhage. Now, beyond that, it is going to be called as major. So there is no moderate variety in the case of the postpartum hemorrhage. So directly it is minor, it is major, or it could be massive. Okay, so if it is between 1 liter to 2 liters of the blood loss, that is going to be called as the major postpartum hemorrhage. Next, what we have is any amount of the blood loss which is going to be more than 2 liters, that is almost more than 50% of the mother's volume, that is going to be massive postpartum hemorrhage. Okay. Now, I already talked about the types of the hemorrhage. That is it going to be primary postpartum hemorrhage or it is going to be secondary postpartum hemorrhage, depending upon the time duration that is between the immediately delivery as well as the delivery of the placenta and 24 hours, or after the first 24 hours have been completed and the 6 weeks of the puerperium. So on the basis of that, we are going to define is it a primary postpartum hemorrhage or it is going to be the secondary postpartum hemorrhage. Now, if we talk about the primary postpartum hemorrhage, there is a third stage hemorrhage or there is true postpartum hemorrhage. What do you mean by that? In case of the third stage hemorrhage, which means the placenta is still intact, is not delivered. Okay, and in the true postpartum hemorrhage, the placenta has been delivered. Okay. In the case of the secondary postpartum hemorrhage, which is after the 24 hours of the delivery of the baby, the development of the bleeding takes place, and for which the most common cause would be the retained products of conception. Okay, this is going to be the most common cause. Which is there is some products of the conceptus, that is certain placenta or the membranes which are present inside the uterine cavity, which hinder with the proper contraction of the uterus. So that was about the types. Now we begin with what is postpartum hemorrhage, which is primary variety. So if the blood loss is going to be more than 500 ml from the genital tract during normal delivery or more than 1 liter following cesarean section, that is defined as the postpartum hemorrhage, which is primary variety within 24 hours of the delivery. So there are certain risk factors which are actually existing, which predispose any mother to the development of the postpartum hemorrhage. So you can consider that on the basis of certain history or the antepartum hemorrhage or certain intrapartum factors, that is during the labor process, or certain miscellaneous factors. Okay. So you need to understand the normal physiology. So before going to that concept, I'll be explaining you a little basic. So let's consider this as the uterus. And what happens is these are the interlacing fibers which are coming through which the blood vessels are passing. Okay. So what happens is once this uterine muscles have the unique property of the contractility plus retraction. And what do you mean by retraction? Means the permanent shortening of the uterine muscle fibers, and they do not, once the contraction is over, they do not go back to the similar length. So they stay, once contracted, they are going to stay of that particular shortened length. That is going to be called as retraction. So now the blood supply to the uterus is majoritarily is coming from the uterine arteries, and these uterine arteries are going to give branches, and ultimately these branches travel through the uterine myometrium, which is going to be arranged in the crisscross pattern of the muscle fibers. So let's consider this as an image of the uterus. The uterine artery, the branches are going, it traverses to the uterine myometrium, ultimately going to the placenta. Now, in between that, there are various small arterioles, which are going to be called as, these are the spiral arterioles. Okay. Now, while they are traversing, what happens is there is this crisscross arrangement of the muscle fibers is present. And once the delivery of the baby is taking place, the uterine size is going to shrink. It goes to this smaller size. There is sudden contraction of these muscles as well as retraction taking place, and which causes the occlusion of these arterioles. Okay, so there is this occlusion plus kinking. So effectively, you can consider there is the physiological ligature of these vessels which is taking place with the help of these muscle fibers. Okay, so what you call is this is going to be called as the living ligature. Okay, so this is called as a living ligature, and this mechanism is the one which is helping prevent the development of the postpartum hemorrhage. Because what happens is, because of during pregnancy, what happens, there is increase in the blood flow to the uterus to as high as 500 ml to 800 ml per minute. So this much amount of the blood per minute is going to go to the uterus. Now, because of these closure or physiological closure of these spiral arterioles, what happens is this amount of, which is as high as 500 ml of the amount, which is roughly 15% of the cardiac output, that much amount of the blood loss is prevented with the help of the physiological living ligature. So that was about a short explanation of how it is prevented. Now we come back to the risk factors. So if we talk about the risk factors, there are certain factors which are based on the history. So if we talk about the history, what happens, that is, if the mother's age is advanced, it's an inherent risk factor. Second is, I mentioned the development of the anemia or malnutrition, where the uterus is not going to contract properly, number one, as well as it is the amount of the blood in the body is also going to be low. Second is history of the previous postpartum hemorrhage, previous fibroid in the uterus, as well as the bleeding or the coagulation disorders. So that is the based on the history. Certain factors during the pregnancy, which is called as the antenatal risk factors, what happens is there risk of the antepartum hemorrhage, or there is some kind of infection of the placenta as well as the amniotic membrane, which is going to be called as chorioamnionitis, or there is over distension of the uterus. What happens is the uterus is going to be overly distended, and as a result of which it cannot contract properly. So that is going to be called as the overly distended uterus, which is seen with the case of the multiple pregnancy, or the baby is going to be big, as in the case of the diabetic mothers, or it is going to be distended because of excess amount of the fluid, which is going to be called as the polyhydramnios. Lastly, you have the intrapartum factors, that is certain factors during the labor which are going to help, which are going to predispose to the development of the postpartum hemorrhage, such as the prolonged labor, or it could be because of induction of the labor with the help of either cerviprine or the oxytocin, or the patient has precipitated labor, that is a sudden development of the delivery, expulsion of the fetus with as low as short duration of less than 2 hours, or you're using the other external factors such as the instrumental delivery, forceps or vacuum, which is predisposing to development of the traumatic PPH, rupture of the uterus, or any kind of genital tract trauma, or you're using the oxytocin injudiciously. Lastly, we have the certain miscellaneous factors such as the sepsis, where a generalized inflammatory condition is produced, which hinders with the development of the contraction of the uterus. So that was all about the risk factors which are associated with the postpartum hemorrhage. Now, broadly classifying, why does this postpartum hemorrhage take place with context of locally, if you're talking, there are 4 T's which are responsible. Okay, so either there is the problem with the tone of the uterus, that is T stands for, first T stands for the tone of the uterus. The second T stands for any kind of injury which has taken place. So any kind of trauma which has occurred, either it could be trauma starting from the uterine, inside the uterus, it could be either the cervical trauma or it could be the vaginal trauma, or lastly we have the perineum. So any kind of trauma which is occurring in the whole pathway of the uterus, or there is some kind of the tissue which is present inside the uterine cavity which prevents or which hinders with the uterine contractility. Okay, so any kind of the tissue which is present inside the cavity, which is more probably retained products of conception or the whole of the placenta. And lastly, we have the thrombosis or the abnormalities of the coagulation pathway. So all these, in all, you divide, if you want to know why this kind of PPH is developing, you can divide it into more commonly a broader classification, that is 4 T's: trauma, tone, tissue, and the thrombosis. So talking about the first topic, that is first T, which is going to be the tone, that is bleeding is taking place from the placental side because of the decreased tone of the uterine muscles. Okay, so the uterine muscles are not able to properly contract and thus are not able to occlude the spiral arterioles by the physiological ligature, and as a result these sinuses or these spiral arterioles are going to remain open and the blood loss starts from them, or it stays continued. So this is more commonly seen when the uterus is going to be over distended. That is, since the uterus has been enlarged so much, it cannot properly contract. This is seen with the twins, large pregnancy, or the polyhydramnios. Then if it is poorly perfused patient, that is the patient is itself has hypotension or she has anemia, or the labor was prolonged, that is delayed uterine retraction as well as contraction following the delivery of the fetus, induction of labor was done, or there is high parity. Now this high parity is one of the major risk factor. What you more commonly seen in India is the high parity, and there are very high chances of the development of the inadequate retraction of the uterine fibers, as well as there is, because of the previous injury or the previous labor, what happens, there is past history of the injury to the decidua of the uterus, and as a result it predisposes to the development of the adherent placenta, which is morbidly adherent placenta, which again predisposes to development of the postpartum hemorrhage. Lastly, you have risk factor of the chorioamnionitis, that is there is generalized inflammatory state of the uterus as well as placenta, and the uterus is unable to contract properly, as well as the use of the hydrocarbons in case of the general anesthesia, which is going to hinder with the contraction of the uterus. Next, you talk about the trauma, where you're going to see that there is injury to the blood vessels along the genital tract, and it can lead to the development of the bleeding from those torn blood vessels. So it can be seen in the case of the large episiotomy which has been given, and it can extend this episiotomy. If it is extended superiorly, it can involve the injury to the deeper blood vessels, or there is any kind of the laceration to the perineum or to the vagina or the cervix. So, okay, more commonly what you see is the cervical tear. Okay, so if the cervical tear is seen, then there are very high chances that the bleeding might continue. Lastly, you have rupture of uterus, and one more common thing is maybe that there is development of the hematoma, which could be the supralevator, or it could be the infralevator. This supralevator may even extend to the broad ligament hematoma. Okay, so that was about the trauma. That is the second T. Next, we come to the third T, which is going to be the tissue. That is more commonly inside the uterus. What you have is the certain amount of the tissue which is present in the uterus, which prevents the uterus from contracting and retracting properly, with more probably the retained products of conception. Okay. Sometimes there are abnormalities of placenta, such as there might be another lobe or accessory lobe, or it could be a bilobed placenta, or there is accentuate lobe of the placenta, there is another lobe. Then that following the delivery of the placenta, that particular lobe stays inside the uterus, and this can lead to the development of the postpartum hemorrhage. And lastly, we have a deadly condition which is going to be called as the morbidly adherent placenta, where the placenta is going to be adherent to the myometrium of the uterus. Okay, so there is no intervening decidua. So there is no plane of cleavage which is seen in such kind of the placenta. Lastly, we have thrombosis, or there is abnormalities of the coagulation pathway. So in case of the thrombosis, what happens is there might be the patient having congenital abnormalities or the acquired coagulation or the bleeding disorders. But there are certain conditions in pregnancy which are predisposing the mother to the development of the bleeding following the delivery. So this particular conditions which are associated with the abnormalities of the coagulation pathway include the development of the placental abruption, which predisposes to the development of the disseminated intravascular coagulation, that is DIC, where there is sudden consumption of all the coagulation factors. Okay. Secondly, we have is the jaundice, which is one of the deadliest condition if it develops in the pregnancy, and it can lead to very high risk of the maternal mortality. You have thrombocytopenic purpura, and lastly, you have a complication of the preeclampsia, where it is development of the HELP syndrome, which is going to be hemolytic anemia, along with that increase in the level of the liver enzymes, that is elevated liver enzymes. And lastly, you have the low platelet count. Because of the low platelet count, as well as the abnormalities in the liver, what you see is the decrease in the coagulation factors. Along with that, decrease in the level of the platelets. Both of them are responsible for the clotting mechanism of the blood, and that is what is seen in the case of the HELP syndrome, which predisposes to the mother to the development of the postpartum hemorrhage. So that was all about the 4 T's what we see. Next, how are you going to diagnose and manage such a condition? So what happens is, this is something which is seen only if the obstetrician is sitting inside the labor room. What happens is, following delivery, the placenta has been removed. Now, it is only clinically you are able to visualize that the mother has developed excess amount of the blood loss. Okay, what you are going to see is the amount of the blood which was delivered, or which was coming out per vaginal, which is going to be more than that of the normal. Or sometimes it can be seen in the form of the concealed variety, which is going to be if the mother is going to have hematoma, which would be the vulvovaginal or the broad ligament. Okay, so what you see is, indirectly, this is going to produce the clinical effects, which is it is going to affect the vitals. Okay, and this is going to depend on the changes in the vital are going to depend upon the amount of the blood loss, the rate at which the blood loss is occurring, as well as the pre-existing, that is the antenatal hematocrit, which is going to be responsible for the changes in the vitals. So how you are going to see or assess the further manage such a patient? So firstly, you are going to check the uterine tone. Okay, this is one of the, we know that there are 4 T's which are responsible. So all of that, if it is because of tone, or it is because of the decreased tone of the uterus, what happens, it leads to massive blood loss. And this is something which can be prevented with the help of the uterotonics. Okay, so first is you have to rule out that is it the condition of excess bleeding, is it because of amount of the decreased uterine tonicity. So what you're going to do is you are going to put your hand on the uterus and check the tone of the uterine muscle. Okay, if the uterus feels soft and becomes hard only intermittently on uterine massaging, then you can clinically diagnose that it is because of the atonic uterus. So you just have to put your hand on the mother's abdomen and check the tone of the uterine muscle, see whether it is soft or whether it is firm and hard. If the tone is going to be good, then that means it effectively rules out the cause could be atonic PTH. No, there are other causes which could be either because of trauma or tissue or because of the thrombotic abnormalities. Sometimes both can even exist. Along with the decreased tone of the uterus, there could also be existing internal trauma which has taken place. Now, there are certain the vital parameters which have been developed to assess the amount of the bleeding. So what you need to understand is that there is a shock index, which means that heart rate upon the systolic blood pressure. The normal value is going to be 0.5 to 0.7, and this gives a good estimate about the amount of the blood loss. So if normally, if you're sitting in a trauma, in a surgical trauma, what happens is the rate of, if this shock index is going to be more than 0.9 to 1.1, that means there is a requirement of intensive resuscitation. But in case of the obstetric shock index, what happens is in the pregnant females, this ratio has been decreased to 0.7 to 0.8. And if it is going to be more than 1, that means it is going to be a massive hemorrhage, which is approximately more than 2 liters, and there is an urgent need for the blood transfusion. So the values are changed in the case of the pregnant female from that in the case of the traumatic patient. Apart from that, there is another grade which is developed, which is called as the urgency grade. Okay, so which helps in understanding how much amount of the shock has been developed, whether it is a compensated shock or whether it is already into the level of the decompensation, and various grades have been developed. So depending upon the amount of the blood loss, let's say if it is between 500 to 1000, the patient is going to have normal blood pressure, but it is going to cause the stimulation of the sympathetic system, which leads to the palpitation as well as the mild tachycardia as well as dizziness. And here the amount of the blood loss is still less than the massive blood loss, and the obstetric shock index is going to be less than 1. So here it is going to be a compensated variety of shock, which is done by the compensation with the sympathetic stimulation. If the blood loss continues to occur despite the sympathetic system stimulation, what happens is it is unable to manage, or it is unable to compensate, and what happens is there is slightly more fall in the blood pressure which takes place. So systolic blood pressure is going to be between 80 to 100 mmHg, and along with that, here the diastolic blood pressure is going to increase. Okay, so diastolic blood pressure increases, because of which the pulse pressure is going to increase. Patient is again going to have tachycardia as well as sweating and mild weakness, and this is going to be called as the mild grade 3 kind of the shock. Now, if the blood loss still continues further, which is about more than 1500 to 2000 ml, what happens is that is going to be roughly 40% of the blood volume. The systolic blood pressure is going to further fall, which is going to be as low as 70 to 80 mmHg, and this patient continues to have tachycardia, as well as what you see clinically is the pallor, and the blood starts to be, there is shutting down of the kidney which takes place, that is the oliguria starts to develop at this particular stage, and the obstetric shock index is going to be more than 1.5. This is going to be moderate grade 2 variety of the urgency grade. Lastly, if the blood loss is going to be more than 2000 ml, what happens is there is marked fall in the systolic blood pressure to as low as 50 to 70 mmHg, and this is a stage where the complete kidney failure or shutdown takes place, and the patient is going to develop the N-urea, and the obstetric shock index is going to be more than 2, and this is going to be severe grade 1 of the urgency grade. So to prevent the development of all these kind of the complicated, what we see in the mother, that is the mother predisposed to the increased amount of the morbidity and mortality, what we do is we develop certain measures. I earlier in the part of this lecture, I told that there is the development of the active management of third stage of labor, which has been developed in such kind of, for the prevention of such grave consequences, as well as the delivery should be slow and gentle. Why? Because if it is done in the rapid manner, what happens is increased chances of the trauma to the genital tract, and as a result, we are iatrogenically producing the traumatic variety of the postpartum hemorrhage. Next, you do not go for the Credes compression method. So initially there was this method of the delivery of the placenta where the anterior and the posterior wall of the uterus were compressed. So this anterior wall and posterior wall were compressed and the placenta was squeezed out, which was called as the Credes method. But this is not done, because if you're trying to do this, then you can predispose to the development of trauma to the uterus as well as the complete inversion of the uterus which is taking place. So this is avoided. Next, we assume that during the delivery of the baby, what happens is there might be chances as predisposition to the development of the trauma to the genital tract, and as a result, routine exploration of the genital tract should be performed using the two speculum, and you should always see that there is any kind of trauma is not present inside the vagina or the cervix or the perineal area, as well as particularly the paraurethral area. Okay, so that is about the how you're going to prevent such thing. Now, if a patient is sitting inside the labor room, you are there at night and you are delivering, what happens is this patient had sudden development of the postpartum hemorrhage once you delivered the placenta. The bleeding came so fast. So how are you going to manage such a case? So first is you have to immediately call your seniors as well as all the other staff and make them alert that such kind of situation is occurring inside the labor room, and do not try to manage it alone. So always go for the group management, that is called for help. Now that's the first step. Okay, call a senior obstetrician as well as anesthetist for assessing the patient's status, as well as the extra help with the help of the sister or other staff which is present inside the labor room. So what you do next step is going to be massage the uterus to make it hard. So this is going to help in the increasing the tone of the uterus. So mind well that the massage is a part of the, not the active management of third stage of labor. Massage is going to be the treatment, okay, treatment of the development once the PPH has already been developed. Now what you do is you ask the other staff which is existing there to put 2 large bore IV catheters. So 2 large bore, where you're going to go for 14 gauge of the intravenous catheter and cannula, which is of the 14 size gauge. Okay. And simultaneously, you have to send certain amount of the blood, roughly 20 ml, which is taken, which is sent for various investigations, which I'm coming to, and simultaneously start fluid, start crystalloids. And in such a patient, crystalloids are always preferred over colloid. Okay, so in a postnatal patient, what you're going to do is, if the patient is developing the postpartum hemorrhage, you put 2 large 14 gauge intravenous cannula and take blood samples. Simultaneously, you connect at least around 2 to 3 liters of the ringer-lactate or the normal saline that is passed through these IV line. Okay, so second is this, you are sending the blood for investigation. So your next aim is to send the blood for blood grouping and cross matching, because blood is getting lost. So best replacement for blood is going to be the blood. So what you're doing is you are sending the patient blood for the investigations, where you are not only going to send for the blood grouping and cross matching, along with that you will check what is the level of the hemoglobin, that is done by CBC. So you check blood group, the hemoglobin, as well as the platelets. So these two are done. And if hemoglobin, what it is, you can get a better picture with the help of the hematocrit, which is the packed cell volume. Along with that, you simultaneously also go for checking the level of the urea, creatinine, as well as electrolytes, as well as liver function test, and clotting time, which is going to be the bedside test. And if also available, you can go for the PTINR and fibrinogen. Now, if you have the bedside test, which is the clotting time as well as the bleeding time. So what happens is, if the formation of clot takes place in 10 minutes, that means in that particular sample of the blood, there is adequate amount of the fibrinogen to suffice the management of the PPH. Whereas if the retraction of the clot is taking place in 1 hour, which means there is adequacy of the platelets. So these are 2 simple tests which are actually done bedside. Next, you go for the assessing the vitals of the patient. So you have to check the vitals, which includes the temperature, it includes the pulse, it includes respiratory rate, it includes the SpO2 of the patient, and blood pressure. So these are the vital signs you see. Along with that, we all know that if the further blood loss is going to take place, that is going to compromise the urine output of these patients, and therefore you also go for assessing the urine output with the help of the catheter. Apart from that, what you go is you measure the amount of, you just in the notes, what you're going to also write is the amount of fluid which is given to the patient. So input output charting is done, along with monitoring of the vitals, which is done. Okay, and all the drugs which are going to be given to the patient are again recorded. So that is, record maintaining is very important. So once this resuscitation of the patient is done, so first step was what? It was resuscitation of the patient. Along with that, you are sending the investigations. You need to, next step is to see the confirmation of diagnosis, that what exactly is causing PPH in such a patient. So what you're going to do is you're going to check the tone of the uterus. Next, you're going to check explore the uterus, that any kind of the trauma is taken place to the uterus or the cervix or the vagina or the perineal area. So you go for assessing the tone of the uterus, you check out for the trauma, and lastly you go for the bleeding and the clotting time. Okay, once that is done, you see the placenta. So what you need to see in the placenta is whether it is being delivered or not. If it is not delivered, you deliver it. And if it has been delivered, you need to check for the intactness of the placenta. That is, check that placenta has been completely, all the lobes of the placenta have been delivered, or is there any kind of the missing lobe. If there is missing lobe, you have to go for exploration of the uterus, and that has to be removed, okay, with the help of ovum forceps. So once the confirmation of diagnosis is done and you see that there is atonic PPH, okay, is there any kind of atonic PPH, what you need to go for is need to go for the uterotonic agents. Okay, what are these? These are also called as the ecbolics. Okay, once you're giving this uterotonic agents, these are going to cause the flabby uterus to contract and make it a firm and very well contracted, and thus helping the occlusion of the placental bladder as well as the bleeding which is taking place from these tone sinuses is going to get controlled. So number one drug we have is the oxytocin. So we already know that we were giving oxytocin prophylactically in the active management of third stage of labor, which was given intramuscularly 10 units. What you're giving in the management is 10 to 20 cc of the 20 units of oxytocin is given in the intravenous drip, which is going to be in the 500 cc of NS or Dinger lactates, which is Hartmann's solution, at the rate of 40 to 60 drops per minute. Okay, you can also use the concentrated oxytocin if this does not work. So which can be the concentration can be increased to 40 units. Okay, so that is about oxytocin. Again, I would like to repeat that there is this parenteral use, which is given in a drip version and not IV bolus, which can cause the sudden development of the hypotension. Next, we have is the ergomytron or the methyl ergomytron, which is given in the dose of 0.25 milligrams, or it is given as 0.2 milligrams of the methyl ergomytron, which can given be both intramuscularly as well as intravenously. If needed, it can be repeated after 15 minutes. And once the second dose is repeated after 15 minutes, for the maintenance, you can repeat the dose after 2 to 4 hours. But the only problem with this methyl ergomytron is that it is going to cause not only it is going to cause the uterine contraction, but it is also going to cause the peripheral vascular contraction. So this causes increase in the blood pressure, and therefore it is strictly contraindicated in a patient who is having preeclampsia or gestational hypertension, or patient is having cardiac disease and the Rh negative mother. You need to understand the two differences. Whenever you're going to give oxytocin, what happens is this oxytocin is going to mimic a physiological uterine contraction. That is, it is going to cause the upper segment to contract. It does not affect the lower segment. Okay, so the upper segment is tonically contracted. That is a physiological pattern. Whereas if you are going to give the methyl ergomytron, what happens is this is not only going to cause the contraction of the upper segment, but it is also going to cause the lower segment contraction. So both are contracted, which produces a tetanic variety of the contraction. Okay. So that was about the two drugs, oxytocin, methyl ergomytron. Next we come to is the prostaglandins. Okay, so we have two agents in the prostaglandin, which is the 15-methyl prostaglandin PGF2 alpha, and the other one is going to be the mesoprostol, which is going to be PGE1. Okay, so if we talk about the 15-methyl PGF2 alpha, the brand name is going to be, the other name is going to be the carboprost, and more commonly what also uses the prostodine. Okay, so this is given in the dose of 250 micrograms. Okay, there are ampules which are available, which contain it is given in the, it is inside the labor room. It exists in the vial. Each vial contains 125 micrograms. So you have to fill 2 vials. So total of 250 micrograms of the carboprost has to be given. which can be given by two routes. Okay, so mind well, carboprost has to be given intramuscularly and never as IV bolus. Okay, so it can either be given inside the as the intramuscular injection, or it can be given as the intramyometrial, which is given during the cesarean section, intramyometrial. The side effect produced with this is the development of diarrhea along with that vomiting, tachycardia, pyrexia, bronchospasm, particularly in case of asthmatic patients. If we talk about the mesoprostol, the dose is going to be 800 micrograms, which is given sublingually. It can also be per rectal or orally. And this mesoprostol, the advantage is that it can be given in the case those who are having asthma, because it does not act on the lung. So this, in case of asthma, you can give mesoprostol, but you are not supposed to give the carboprost. Next we have is the tranexamic acid. Okay, so this is going to be an antifibrinolytic agent, which is given at the rate of, it is given as 1 gram, which is around 10 cc. The 1 gram, which is given as 1 ml per minute, administered slowly over 10 minutes within 3 hours of the birth. So that was all about the uterotonic, which is alcoholic, as well as the tranexamic acid, which is an antifibrinolytic agent, which helps in the thrombosis. Next, we talked about the resuscitation, assessing the tone of the uterus. That is, if the uterus is statonic, you give the drugs to cause the increase in the tone of the uterus. Along with that, as I mentioned, the best replacement for the blood in the case of the postnatal patient is going to be the blood component therapy. So you have to preserve at least 2 units of the blood, and depending upon the amount of the blood loss, you can go for giving the blood. Now, if at all the requirement of 3 packed cell volume, which is containing the red blood cells, is given, then simultaneously you have to give simultaneously fresh frozen plasma. And if there is a decrease in the level of fibrinogen inside the blood, then you also need to add the cryotherapy or the cryoprecipitates to this patient, which helps in replacing the fibrinogen or the clotting factors which have been lost. Okay, so that was about the blood component replacement. So again, simultaneously, the ongoing, once you're giving these drugs to the patient, what you need to also simultaneously assess is the tone of the uterus, as well as you go for the exploration of the genital tract for any kind of the trauma. Despite giving these drugs, if the uterus is still not contracted, okay, what you need to do is you need to go for the uterine massage as well as the bimanual compression. So as you can see in this picture, there is this process which is called as the bimanual compression, which is done. So with the help of the dominant hand, which is the right hand, it is inserted inside the vagina in a cone-like manner, with the left hand helping it to separate the vulva, and thus easy insertion of the right dominant hand is done, which goes in the anterior fornix. As you can see, this is going to be the anterior fornix, and it presses or compresses the anterior wall of the uterus. Simultaneously, with the help of the non-dominant left hand, what you're going to do is you're going to press upper abdominally on the posterior wall of the uterus, because of which what happens, you're squeezing these two walls between the two hands. One is the fist and the other is the other hand, which is present on the abdomen. You're going to squeeze the whole wall, thus preventing excess amount of the blood loss. Okay, so that is going to be temporary method, and wait for the uterotonics to come into action, and this increases gradually the tone, and this helps in the bleeding, preventing the bleeding. So that was about the uterine massage and bimanual compression. Okay, even if it does not prevent in the development of the prevention of bleeding, what do you need to proceed with the next step, which is the intrauterine packing. So in case of intrauterine packing, what you're going to do is you are trying to give a tamponade effect. That is, tamponade means the pressure effect. So with the help of the external pressure, you're trying to compress the uterine sinuses from which bleeding is coming, and trying to prevent it's an attempt. So initially it was considered as one of the treatment, but WHO has currently stated that it is actually not a treatment. It is just a temporary method where it helps in buying time. So let's say if I am sitting in the periphery and I am delivering a patient, she developed postpartum hemorrhage. I gave all the uterotonic agents, but it was not able to act on the uterus. Still, the tone of the uterus was flabby, what happens is I need to transfer the patient to such a center, that is a tertiary care center, where all the facilities of blood transfusion as well as senior obstetricians would be available, team would be available, which helps in the postpartum hysterectomy. So for that, I need to transfer the patient. So I can't transfer the patient like that. What I need to do is I have to stop the bleeding temporarily with the help of the intrauterine packing. So that is going to be a temporary method so that the woman can be transferred from a peripheral or the primary health center to a tertiary care center. So here a 5 centimeter long gauze is taken. It is 8 centimeter wide, which is folded on itself, and it is aseptically with the help of which is soaked in betadine. It would be packed. What you do is, let's say, consider this is the uterus. We pack the uterus from the fundus. We gradually come down, and as a result, a tamponade or a pressure effect is produced, and we write all these how many packs we had kept inside the uterus, as well as how many packs we had kept inside the vagina. So this uterus and vagina are packed separately, and the patient is transferred. So that is going to be a temporary method, and you have to remove. You cannot keep a pack inside the genital tract for more than 24 hours. If it is kept inside the genital tract, what it is going to do is it is going to cause the sepsis, and the patient may die out of sepsis. So that is the duration of the intrauterine pack. Now, instead of pack, what you can also go is using the catheter and the intrauterine catheter. So one of them is going to be the Sengstaken-Blackmore's esophageal catheter. So as you can see in this picture, so very clearly there is this gastric balloon which is kept inside the uterine cavity, and more particularly in the lower segment. Okay, so this is more particularly kept in the lower segment. You inflate this gastric balloon with the help of around 200 to you inflate this gastric balloon with the help of the, just 1 second, my battery is low, but sorry for that problem. Sorry, students, for this disturbance. Yeah, so we come back to what I was saying. The Sengstaken-Blackmore, the gastric balloon is inflated inside the lower uterine segment with the help of around 200 to 500 ml of the warm saline, and you need to keep this amount of warm saline filled inside the vagina and the lower uterine segment for at least 24 hours. What you are going to do is, with the help of this, you are going to do is a tamponade test checking. Means what? So you are giving a pressure to the uterus, and you're checking that if with the help of this balloon, if the pressure is being applied to the uterus, if it is able to stop the bleeding, that means the tamponade test is positive and you do not need to go for further operative management. But if it is negative, which means what? That despite the pressure, the blood is still coming out from the uterus. What you need to go is, you need to move on to the next step of management. That is, you go for the surgical management, and that means it's an indication for either laparotomy, and you need to further do the next step. So that was all about it. And apart from these two catheters, we also have the variety of other catheters available, which is going to be the Bakri balloon, or you can also use the condom catheter. Okay, so these are the other varieties of the catheters which are available to prevent the bleeding and go for the tamponade test. The other measures which are available is the military anti-shock garment or the treatment. Here, a giant blood pressure is applied to the periphery. It helps in transforming the blood from the periphery and to the abdomen, and the blood to the vital organs is blood supply to these organs is going to be restored. The other method is going to be the external aortic compression. So all these measures help for the transfer of the patient from the peripheral health center to the tertiary health center. So these are all temporary measures. Lastly, we have, once this patient, if the tamponade test is also negative and the bleeding continues, we need to go for laparotomy. And in the laparotomy, there are various methods what you go for. Either you can go for compression sutures, you can go for stepwise uterine devascularization, you can go for the uterine artery embolization, or you can go for the hysterectomy. Now, what is the principle behind this? You need to understand that we need to understand that the uterus is getting its blood supply. Consider this as the uterus. It is getting its blood supply from the uterine artery. A branch is also coming from the ovarian artery, and the bleeding is getting continued. Okay. So our main purpose is to stop the bleeding. So either you can go for the apposition of the anterior and the posterior wall of the uterus, number one. So that is one of the measure which is available. The second is the blood supply. We just can cut these blood which is coming from these vessels. Okay, so we go for directly ligating this blood vessels. If that is also not available, we directly remove the organ which is actually causing the bleeding. So these are the three principles how we are going to stop. So I will be explaining each of these in detail. So what happens is, first we begin with the compression sutures. So here the principle is that we are going to let's consider this as the anterior wall of the uterus and the posterior wall of the uterus. So by a compression or by the external sutures, as the name suggests, we are going to compress the anterior wall of the uterus and posterior wall of the uterus, which helps in preventing the bleeding from the sinuses, which are the source of the blood loss. So there are varieties of the sutures which are available. First is going to be the B-length suture. The second is the Hemo suture, then multiple Cho Square suture, and lastly we have the ischemic cervical suture. So if you talk about the B-length suture, this is here one suture. Let's consider we begin passing the suture from one point or the lower part of the suture. Just follow my marker. What happens is we pass the suture from lower end of the lower uterine segment. It is removed from the upper uterine segment, and posteriorly we go and pierce it anteriorly. Okay, once this is pierced inside the cavity, we shift to the other side. Okay, and this suture is again passed from the anterior wall on the other side. We go posteriorly, again it removed, and we are removing the needle from the lower segment. Thus, what happens is this suture is tied, and what we are using is the chromic, which is going to be the absorbable variety. Once this is used, what you are going to do is externally we are going to compress the uterus, and this uterus ultimately folds upon itself, and this helps in preventing the blood loss. Okay, so that is the principle behind the B-length suture. Second we have is the most commonly used is the Cho Square sutures, where the sutures are taken in the form of the crisscross in the multiple number on the surface of the uterus, and thus at different levels, the anterior and the posterior wall of the uterus are going to be opposed. Okay, so that was the principle or the talking about the compression sutures. If this does not work, what you need to do is, as I mentioned earlier, so if the area on uterus is not working, what do you need to do? Go to the next level is the source of the blood, that is the blood vessels which is applying to the uterus are to be ligated. Okay, so we all know that one is the uterine artery, which is going to be the branch of the anterior division of the internal iliac artery. Next, we have a branch which is coming from the tubal branch of the ovarian artery. Okay, so all these are going to supply the uterus. So these are the ultimate source of the blood supply to the uterus. We are going to ligate them. So first is you go for the unilateral, that is one-sided high uterine artery ligation. If this does not help to prevent the blood loss, we go for the bilateral. So bilateral high uterine artery ligation. Even if this step does not occur, we go for the bilateral low uterine artery ligation. Next, we go for we know that there is this site of anastomosis, which is going to be the tubal branch of the ovarian vessel. We are going to ligate that on both the sides. And lastly, if this does not work out, then we go for the internal iliac artery ligation on both the sides. Okay, so that is called as the stepwise devascularization of the uterus. That is, we go for stepwise, we go for ligating all the blood vessels which are going to go and supply the uterus. So first is the uterine artery ligation. So we all know that the blood supply to the uterus, the main source is going to be the uterine artery, which is actually a branch of the anterior division of the internal iliac artery, which is again in turn a branch of the common iliac artery, which is a direct division of the abdominal aorta. Okay, so uterine artery is going to supply 90% of the blood supply to the uterus. So that is logically it is going to be, if blood coming from to the uterus is 90% is coming from the uterine artery. So first step should be the ligation of this vessel. Okay, so you are going to pass a ligature, the level just below the lower uterine segment incision. So wherever you have kept the incision for the cesarean section, just below that you can go for ligating this vessel, keeping certain chunk of the myometrium to the one side onto the medial side, and laterally inside the broad ligament you do not need to keep any other tissue, because there are very chances that the ureter is going to be very near and there are chances of injury to the ureter. Okay, if this does not function, then what you need to do is the next step, which is the ligation of the ovarian as well as the uterine artery anastomosis, which is going to be the utero-ovarian artery anastomosis. This is done just below the ovarian ligament and it is done on both the sides. Okay, bilateral ligation is done. Now, the blood supply from the uterus, both the uterine as well as the ovarian sources are ligated. Still, the blood is coming to the uterus. Then what you need to go for the next step, which is the source we know is the internal iliac artery. Okay, so next step is the internal iliac artery ligation. So as you can see in the picture, this is going to be the internal iliac artery, the anterior division. Okay, this is above which is going to be the common iliac artery. One branch it divides into the external iliac, the other would be the internal iliac. And this internal iliac also gives a posterior division. So you need to take care that the other arteries just surrounding it are not ligated. So posterior division is not ligated, the external and the internal iliac artery are not ligated. Only the anterior division of the internal iliac artery needs to be ligated. Okay, so this is done with the help of the right angle artery forceps, and it is done with the help of the silk suture, which is passed from the lateral to medial side. This is going to be a retroperitoneal structure, so you have to actually go dissect retroperitoneally and pass the suture. Okay, once that is done, you have to identify the anterior division and just ligate it. Once this procedure is done, very important step is just confirm that the external iliac artery is not damaged, and this is done with the help of the femoral pulse checking, because ultimately the external iliac continues as the femoral artery. Okay, so this once this process is done, what you need to assure is that this is going to reduce the pulse pressure by 85%, and hence the clotting can take place. Okay, so that is about the internal iliac artery ligation. Now, let's consider that patient has been managed with this way, and there is slight patient becomes hemodynamically stable, and slight amount of the blood loss is still going on, means the postpartum hemorrhage is still going on, but the patient is hemodynamically stable. One of the boon which has been given by the interventional radiology is the selective uterine artery embolization, which can be done only if the patient is hemodynamically stable, but there is slight trickling of the blood which is taking place. And in this condition, what you're doing is you're going to puncture the femoral artery, you're going to pass the percutaneous catheter, and you're going to release the, following the course of the this femoral artery from the external iliac artery, we go to the opposite side of the internal iliac artery and the anterior division which goes to the uterine artery. Ultimately, you release the peg legs of the polyurethane or the polyvinyl alcohol, which helps in blocking the blood to these arteries. So as a result of which the blood supply to the uterus is going to be reduced and stopped, and these small particles of the polyvinyl alcohol can get reabsorbed 10 days later. Okay, so this helps in avoiding the major surgery. Now, the picture I have shown is actually a patient of the fibroid, which is having fibroid. So this uterine artery embolization is actually used for the other two conditions, that is the uterine AV malformations as well as the fibroid of the uterus, but it is also used in the case of the management of the postpartum hemorrhage. Okay. Lastly, despite all these measures, okay, you tried the massage to the uterus, you went for tamponade test, you went for going the stepwise devascularization of the uterus. Despite that, the bleeding kept on continuing and occurring, then what you need to go for is the decision for the obstetric hysterectomy, and that depends upon the age of the patient, the fertility, because this is going to be a radical approach. Okay, so radical, which is going to affect the patient's future fertility. Okay, but this again despite it is affecting, you are going to remove the whole of the uterus, which means hysterectomy, that is removal of the uterus. It is going to affect the patient's future fertility, and therefore you have to think it twice. But if it is, what you need to also do is involve the second obstetrician in taking the decision. And if sometimes it is very much necessary, because despite all the above measures, the bleeding still keeps on continuing, and you need to go for such a radical management where you are going for the emergency or the total or the subtotal. Total means what? The whole of the uterus along with the lower segment and the cervix is being removed. Or sometimes you go for the subtotal, which is where the cervix is being left inside the body and you just remove the uterus upper segment. So that has to be done with the help of the senior obstetrician as a last resort if all the above measures fail. Okay, so that was all about the today's topic, that is the third stage management and the development of the postpartum hemorrhage, where we studied that in the third stage, what you are going to do, how the signs of the placental separation are, what you see it. Next step is going to be the active management of the third stage of labor. And suppose, let's say, the complication of the postpartum hemorrhage develops, what you are going to do, you are going to call for help, you're going to send certain investigations, you're going to assess how and why it occurs. You assess 4 T's, and lastly you go for, if the abnormality of the tone is existing, what you're going to give is the uterotonics. If that is perfectly fine, if there is a presence of the trauma, you have to manage with the help of taking the sutures. If it is still the bleeding is continuing, what you need to do is you need to go for the surgical management. That is the you go for tamponade test, you go for the laparotomy, where you go for stepwise devascularization of the uterus. If all these is not functioning, then you have to lastly go for the hysterectomy. So that was all about today's topic. I hope you guys understood, and that's it. So once again, I would like to thank Dr. Sunil sir for giving us this opportunity and this platform where all of you are benefited with the where sharing of all the knowledge is taking place. Hope you can hope you understood this chapter. And lastly, if you like this thing, just subscribe to our channel. It would help us as well as you, and you will get updated with the future notifications. So that was about today's topic. Okay, have a good night. Thank you, students. हेलो बोलो अरे मैं कट करूँ हेलो मैंने पेलू मोकल रिक्वेस्ट हाँ Yeah, so students, I request you any kind of doubts which you have, you can ask me. Go on. So anyone having any kind of questions, please go on with that. I hope you understood today's topic. So anyone having any doubts, feel free to ask. So I guess no one. So from today's topic, what are the most important things I would like to tell you that the first most important thing would be the methods of separation of the placenta. Okay, so if we talk about the so if we talk about the methods of separation of placenta, what is most important? The Schultz method as well as the Duncan's method. That was the most important topic where you need to emphasize on while you are revising this topic. The second topic would be that what are the causes of the postpartum hemorrhage? That is the four T's which I mentioned that you need to focus on. The next coming to is the drugs which are important. That is the uterotonic agents which you are going to use. That is the oxytocin, the methergin, the dose of the oxytocin, dose of methergin, as well as the carboprost dose where you can give it for the maximum number of 8 times, and the dose which is given in the 250 micrograms. So that all you need to remember, keep it in mind. And lastly, the stepwise devascularization of the uterus, that is going to be the most important amongst all these the topic we discussed today. Okay, so any doubts are welcomed. Any queries anyone has, just feel free to ask. So let's say I begin with the question of the day. So let's say I'm sitting in a labor room. Okay. So I had induced a patient, a primipara patient who was 29-year-old. The induction of labor was done with the help of the ripening of cervix was done with the help of the cerebrum, and the induction was done with the help of oxytocin. Now, the patient was induced at roughly around 9 a.m. in the morning, and the delivery took place at around 11 o'clock in the night. Okay, so the resident who was sitting in the labor room, she calls the consultant and asks that, madam, that there is this development of severe PPH, so what is the next step to be done? So how will you proceed with such a case? So firstly, you need to go for, if she herself is sitting in the labor room, there is no one, what she needs to do is she needs to call for help, number one. Along with that, she has to resuscitate the patient. Okay, so resuscitation is done with the help of two large bore IV lines, and you need to go for giving the rapid fluid, that is the crystalloids and the colloids, to such a patient. Okay, once that is done, what you need to do, simultaneously send the blood for cross matching as well as the blood grouping and arrange the blood. And the next step is assess the tone of the uterus, whether any kind of the tone. Now, in such a case, what happens, the risk factor to such a patient is going to be the induction of labor, which was done. So this is again a risk factor for the development of the postpartum hemorrhage. And that in such a condition, what you need to do is you need to give the tone of the uterus is decreased, and because of which you need to give the oxytocin as well as methergin or carboprost. Those uterotonics are to be given to the patient. Okay, so that is how, if a person is sitting in the labor room, that is, you are supposed to manage a patient of postpartum hemorrhage. So that is about how you're going to deal with such a case. Any queries anyone has? Okay, so now we begin with the question of the day. So let's say in a similar case, now if the patient has, if the resident is sitting in the labor room and she delivered the patient, the same patient who was induced. Now, despite the development of, she was sitting in a primary health center, that is the PHC. Now, what happens is, such patients, she gave all the uterotonics. Okay, so that oxytocin was also given, methogen was also given, carboprost was also given, but it was unable to control the bleeding. So what is going to be the next immediate line of management? So whosoever answers first would be the winner of the question of the day. So, so let's say who answers this question first. Again, I'm going to repeat the question. The question of the day, that you are sitting in a labor room, a primary para who was actually induced, she delivered, she developed the postpartum hemorrhage, all the initial resuscitative measures are done, and she has been given the uterotonics, okay? But despite that, it is not able to help in the contractility of the uterus, and the bleeding still continues. The resident is sitting at the primary health center. What is the immediate next step which is supposed to be done? Whosoever answers this is going to be having the winner of the question of the day. So quick, chalo, answer fast. Okay, so let me give the option. So with options, you can go for the, let's say option A is immediately proceed for laparotomy, or you can go for the option B, which is the you give the trial with the tamponade test, or you go for option C, which is the intrauterine packing and shift the patient to the tertiary health center, or option C is go for immediate obstetric hysterectomy. So which amongst this is going to be the correct answer? So which among the following is the correct answer? Would you like to go for the immediate exploratory laparotomy and go for operative management? Would you like to go for tamponade test? You would like to go for intrauterine packing and transfer shift the patient to the tertiary care center, or you would like to go for the immediate obstetric hysterectomy? So in this condition, the answer would be, since the patient is in the peripheral health center, you have to go for transferring the patient to the tertiary care center with the help of the intrauterine packing. And this is where the patient can be further managed at the tertiary care center, where all the facilities are available. So that was about this question. I hope you guys understood this topic. And in any more questions, they are feel free to answer and ask. So with this, we conclude today's session. I hope you guys enjoyed it and study well. And you can subscribe to our channel, as well as you can go for the link which is mentioned below. You can get the 3-month offer, which is for a very minimal price and which will help you in studying well, which clears your basic concepts, and thus it is going to help you for the future studies. Okay, so hope you enjoy. Thank you. Have a good night.